Swami sir, can we start?
Yes.
Good evening to one and all. I welcome all the delegates who have joined, and a warm welcome to Professor Swaminathan and Dr. Sandeep Karunakaran, who has honored this platform of masterclass series in scale. This is going to be our second episode, and this today we are going to delve upon implantation, a complete overview. So we are going to understand in detail about implantation from Dr. Sandeep Karunakaran. Can we have the next slide, Sindhu? Sindhu?
1 second, ma'am. It's not moving.
Yeah. So the last masterclass, we just will have a few at Sri Chakra Fertility YouTube page. You're free to access it at any time. And as with all the masterclass series, the lecture will be 1 hour. There will be a break at 30 minutes, and we will have few quiz questions and polls. And then we'll also have at the end of the session few questions, and then we will take up A. And Dr. Swami sir will be, summarizing the whole thing at the end of the session as well. We welcome all of you once again. Our next masterclass series will be on March 6th, and it will be all about oocytes, and it will be dealt with our expert speaker, Dr. Rajvi Mehta. Without much ado, I would like to introduce the chairperson of today's event, Dr. Swaminathan. He is the scientific director and senior embryologist. All of us know him. He doesn't require introduction. He is like the superstar Rajnikant all over and always very, very interactive and very scientific. And his expert comments always, remains in our hearts. And he's also a past president of ACE. Welcome you, Dr. Swaminathan. Over to you.
Yeah, thank you very much, madam. It's indeed my pleasure that to join with Scale. Hope that I'll move forward an inch. So it is a great initiative. I appreciate Sindhuja and madam for this great initiative. And today we have a great personality with us, who is Ardhanarishwarar, who can do embryology as well as clinical. It's very rare combination. I tell the crowd that we have very, very, very few people in India who can do both in hand. And it is my pleasure to be with Sir Sandeep Karunakaran sir. I know him very well. He done so many things, and now he is the senior consultant in Apollo Fertility Hyderabad. And I think most of the people in this field we know sir very well. And I'm happy that I'm chairing this session where sir is giving a wonderful insight into the implantation, a complete overview. Thank you very much, sir, for your time to us. Over to you, sir.
Thank you so much, Sandeep. He's a very good friend of mine, and thanks for accepting this. It's a great honor and great privilege to have you here. Thank you much.
Thank you, Vasundara, and thank you, sir. Let me share my screen. I hope it's visible.
Yes.
Yeah.
Okay. Yeah. As Swami sir said, I come from Apollo Fertility. In that entire thing of my so-called CV that was flashed, the last line was the most important one. I don't know why my slides are not moving. Okay. The last line was the most important one, because I am a long distance, of which I am very proud of actually. And I want each and every one of you to actually indulge in physical activity and make yourself more active, not only in academics, but also to look after your own health. So without much ado, and a lot of gratitude to both Swami sir and Vasundara, to invite me over this platform, I start my talk now. In my childhood days, we were taught, we grew up on Star Trek, where they said space was the final frontier. When it comes to our field, Bob Edwards himself said the last barrier in ART that needs to be breached is possibly human implantation. And even today, we haven't understood the nuances of this and this complicated methodology of how the embryo actually embeds itself in the mother's uterus. it rolls in the uterus to find a correct place. And this possibly is the bottleneck of the entire success rate of our IVF procedure per se. So without much ado, implantation, not a complete overview, just an overview, because everything can't be covered in 1 hour. So sorry, Vasundara, I've just slightly changed the topic. I have no commercial interest and all the pictures are just for illustration purposes. Well, I'll go through the entire nuances of this complicated procedure, try to make it as simple as possible. I will be talking a bit on lab aspects and what the embryologist should do or shouldn't do. The clinical part, I'll be actually concentrating a bit on implantation failure, touching upon thin endometrium, because these are the two things which actually affect the implantation rate too much. A bit of error because error has now actually entered the area of controversy. And let's see what we can as a message from this talk. So to introduce the topic, we know that the advances comes in leaps and bounds, but implantation challenge and failure always remains a clinical intricate dialogue between a competent embryo and the receptive endometrium. It is not just putting the right person at the right place and things will work out. The right environment also needs given. And why this happens? No one can answer the entire thing completely. There is no consensus about this entire concept about recurrent implantation failure, or why a competent embryo and a so-called good-looking endometrium still doesn't end up in a pregnancy. The receptivity is the ability for the uterine lining to permit attachment. And it happens in generally a very narrow window of about 4 to 5 days. And this is called the window of implantation, which I'll be actually talking about. And we as clinical practitioners, we want to actually improve this implantation rate. And as I already said, it is the most narrowest part of the cycle, wherein we have to actually still work on the nuances still further, so that we conquer this entire thing called implantation failure. There are a lot of things which which work together, which has to be in synchrony. Only then will implantation really happen. We know that implantation can be defined as the interaction between the seed, that's the embryo, the soil, that's the uterine lining, the endometrium. But what is also important is the environment, that is the general health of the lady. A morbidly obese lady, the implantation rate is definitely going to be low. A low BMI lady will always have less implantation. Anyone who has a problem in terms of infection, thyroid problems, diabetes, that is what I mean. The environment is not right. The implantation is definitely not going to be right. And many a times leads us and a lot of delusions as to why the thing is not really happening. If there is late implantation, there is high incidence of miscarriage. This is clearly reflected in ladies of elderly age group. Fertilization occurs, that is because of lack. Now let us go in slightly deeper into the phases of implantation. There are different phases, and we'll talk about it one by one, especially the attachment part. So penetration blastocyst into the endometrium is what we call as implantation. It generally happens on the 6th day after fertilization and is completed by about 11th day. So we generally transfer a blastocyst, which is day 5. It doesn't stick immediately. It takes about some more time before it actually sticks onto the uterus. And then it is completely embedded by the 11th day. And this period where the embryo looks around for the correct place to implant is called the implantation window. Very short interval, and it is generally present in the secretory phase, and this is the time when the endometrium is most receptive to the approaching blastocyst. It generally lasts for about 24 hours to 48 hours. And important thing out is the integrins, which act as the markers of implantation. We know that endometrium needs to be primed by estrogen and progesterone, and these actually enhance the endometrial receptivity during this period. Already said, synchronized synchronized endometrium presence of a well-developed or accurately developed embryo mean implantation is good. If there is a problem in the endometrial development, endometrial maturity, vis-a-vis the embryo maturity, there will be implantation failure. And that is exactly what we know as window of implantation, generally seen around this point in time. And we can actually calculate that as if it's a fifth day embryo, it is the LH surge plus 6. If you are giving HCG trigger, it is calculated accordingly. And if it's HRT, it would be the fifth day, or P plus 5, or the sixth day of progesterone start. These are the tables that we use to actually calculate the window of implantation in a case where the window is not displaced too much. The first part of implantation obviously begins with fertilization. This happens when the sperm actually enters the oocyte. So this becomes approximately day 0. The second phase of implantation is called as hatching. When the blastocysts get released from the zona pellucida, it breaks the shell and comes out. What does it do after that? The blastocyst slowly rolls. Sorry, why isn't this moving? Okay, I had a video here where the blastocyst was seen moving around in the endometrium. Somehow it's not working. Anyway, so the blastocyst actually rolls down the endometrial lining and finds a place, looks for a certain area which is the best for implantation. This is called as adplantation. Okay, now it's come. So yeah, this is embryo transfer. This is a radio-labeled embryo which was used. And once the embryo has been transferred, this speed is approximately 500 times. And you can see the embryo actually moves around the entire uterus. Of course, this is a pretty long video, so I'll just cut it short out here. It finally moves around for about 48 hours before it actually finds a suitable place to sit down. And once this is a video, the picture of adplantation, where the embryo actually rolls around the endometrium, finds a proper area, and once the correct area is found, there are loose connections which are found between the blastocyst and the endometrium. This is called as apposition. And once the apposition is perfect, stronger bonds are formed, and slowly but surely the embryo starts penetrating into the endometrial layer, and it invades the uterine stroma with the help of the syncytotrophoblast and cytotrophoblast, and that is how the invasion happens. The outer structure is called the syncytotrophoblast, and the inner structures of these attachments are called a cytotrophoblast. And these finger-like processes later develop blood vessels, and that is how the invasion into the uterine cavity takes place. By around day 7, the blastocyst gets implanted. That's the day 7 of fertilization into the superficial layer. By day 10, it has gone into the thing. And by around day 15, the blood vessels actually penetrate from the uterine, the maternal blood vessels enter the uterus and the embryo, and vice versa. After that, there is a protective layer which is formed that is called as desudalization. This is a biological transformation of the outermost layer of the endometrium. And this occurs by around day 23 to day 28. It has certain functions. It forms a local microenvironment to promote trophoblast attachment and invasion. It also prevents further embryos to get implanted. Also, it acts as a protection from the maternal immune response and prevents rejection. That is called as immune tolerance. So this is how it works. The blastocyst enters the uterine cavity, goes out of the zona pellucida, rolls around. The inner cell mass actually gets attached to the endometrial layer and finally gets embedded into it. It is not a very simple procedure as the diagrams actually show. There are a lot of chemicals which are involved in it, and every structure actually releases certain chemicals. The trophoblast releases a huge set of chemicals. The blastocyst secretes its own set of chemicals. The vasculature secretes its own set of chemicals. The most important ones the blastocyst secreting is the HCG, integrins, HLAG. Trophoblasts also secrete integrins, HLAG. The vasculature secretes what we call as VEGF, fibronectin, and integrins. So integrins per se play a huge amount of role. VEGF plays a huge amount of role. And also HCG is the trigger which actually gives us the idea that pregnancy has actually happened. Oh, I'll skip this, but this is the entire set of chemicals that actually work to help us implant. But to cut short the entire thing, these are the major things which actually help implantation between the trophoblast and the endometrium. The CD44, the OPN, the trophonins on either side, the selectin, the Lewis X factor. These are the things which bind between the trophoblast and the endometrium, which causes the adhesions, the first bond to actually form. And this is the beginning of implantation. I think we'll take a small break here for the quiz.
Okay, sir.
Should I stop sharing, Sindhuja?
Yes, sir. That will be nice. So I'll just share a small poll. So all of you can answer from your thing. The answers will be anonymous. So just I encourage all of you to attempt. This is just a quick recap of whatever sir has mentioned. Are you able to see?
Yes.
Nice. I encourage all of you to participate. This is just to keep us all actively involved. I can see active participation by 15% of the audience. Sir, your presentation is like watching a movie, sir. It's really nice. The transitions and the content.
Thanks a lot.
Oh, wow. 43% are participating in the quiz. It's very nice to know. So we'll give a total of 2 minutes for the quiz.
Yeah, take your time.
ये पत्ता रखा हुआ ही है, अभी तो वो खाए नहीं है।
About 75% of the people have participated. So I think we'll just end it in a minute and I'll share the results.
The way the answers are coming up, it looks like most of them have attended your lecture very carefully, and you've got wonderful right answers from majority of the group.
But that's humbling actually, because most of my students generally fail.
Please, don't be a examiner.
No, but I'm actually very proud of my students. Be
Yeah.
be it the army ones where I actually started teaching, to the ones in fertility. And some of them are doing so well. So I'm so very proud of it.
Okay. So it's past 3 minutes and 87% of the people have participated. So I'm ending the poll. Okay. And I'll share the results now. Is it visible for everyone?
Yeah.
Yes. So where does the process of implantation occur in the human female reproductive system? I think 82% have answered that it happens in the uterus. I think some have gotten confused where fertilization occurs. So that happens in the fallopian tube, but implantation happens in the uterus. So how many days after fertilization does implantation typically occur? So majority have answered 6 to 10 days, which is the correct answer. And what is the name of the structure that embeds into the uterine lining during implantation? 91% have answered blastocyst. So I think my questions are too easy. Next time we'll make the questions more difficult. And the trophoblast divides into 79% have answered correctly, outer syncytial trophoblast and inner cytotrophoblast. And the stages of implantation. Sir, did you already cover this, or I think it's coming in the coming slides?
No, it's covered.
It's
Yeah.
covered, yes. So the correct answer is the first option, which is adplantation, and then apposition, adhesion, and then invasion. So I'm happy this was a trick question. So, but still 40% have gotten it right, and the rest who have not gotten it right, I think everyone will know now. So I'll stop sharing and everyone can see the correct answers. Sir, so I'll stop sharing and you can restart your presentations.
The second half, more people will listen carefully and it will be 100%. Next 5 questions will be like, 100% results for us.
Yeah,
Yes,
let's hope.
Thanks,
Okay.
everyone.
Yeah, once the pickup is done, we send our gametes to the lab, and that is where the embryo is actually formed. The first 5 days in an IVF cycle happens in the lab, or the first 5 days of life actually happens in the lab. And lab aspects play a very important role in the entire makeup of the child. So again, I think. Oh God, 1 second, this thing is just not working well. Okay. So I mean, as I said, lab aspects play a very important role. And this has been accentuated by the fact, which was said in the Cairo consensus, and they issued a guideline. So what is important in the lab? Everything. That everything that you do in the lab has an effect on the embryo. It might be small, it might be devastating, but it definitely has an effect. And the role of embryologists become very crucial because they handle the entire thing within their own palms. And we can actually improve the quality of outcome. I mean, the entire quality of the outcome can actually be improved, not only by our actions, but also by preventing certain adverse inactions also. So both actions and inactions affect the quality drastically when it comes to the embryo quality. And embryo quality is one of the most important factors when it comes to implantation. The environment of the lab, be it the amount of VOCs, the air contamination, the particulate matter, the ambient temperature, humidity, everything plays a very important role when it comes to the embryo per se. VOC, air contamination, particulate matter actually affects what we call as the epigenetic change. Temperature and humidity actually affects what we call as the osmolality of the media. Everything has a definite effect on the outcome of the IVF cycle. So a small mistake can be amplified into a pregnancy failure. And what we will know it as is possibly only as an implantation failure. So lab becomes very important. And it is very important to measure all these things repeatedly, periodically, and as per SOP. When we measure the VOCs, we should measure it as parts per billion and not parts per million, because the limit of VOC level is approximately 1 ppm, and the least count of 1 ppm, if there's a least count is 1, and there is always what we call as a slight error, we might actually be working in an area where there is high VOC without even knowing it. So use the correct VOC meter. Frequent calibration is required, and use one of the better equipments rather than the older ones. Temperature, very important. The temperature sensors of the equipment must also be calibrated. Moreover, one must have a secondary check of temperature of the devices so that we do a secondary check too. The culture environment, absolutely important, be it the temperature during ovum pickup, the time taken for ovum pickup, the media that is used, the light, dish preparation, workstation, handling, humidity, everything, every single thing actually matters, even vitrification and thawing. Between the clinician and the embryologist is the ovum pickup, the OPU needle and the machine. The OPU needle, the temperature needs to be actually increased. And how do you increase the temperature of the needle to about approximately 37? You can never make it continuously at 37. This is by flushing prior to the start of the pickup. So a lot of people think we flush the needle to actually increase the lubrication. No, it is not to increase lubrication. It is actually to increase the temperature of the needle, which might not be kept at 37 degrees. Also, depending on the length of the needle, the size, the gauge of the needle, and the length of the tubing, we must actually change the vacuum setting so that the best vacuum is transmitted to the follicle, and the flow of the follicular fluid into the collecting test tube is steady and not in a jerky manner. Cold chain, again, very important, be it media or be it the drugs too. So we must, I mean, most of the reputed manufacturers do assure us that the IVF media or the drugs reach us in correct temperature. We must do our bit by checking the temperature data logs, check the batch numbers, and also promptly put the entire thing back into the cold storage. And when you use cold storage, don't use your domestic refrigerators. Please use pharmacy grade refrigerators, because the fluctuation of temperature is much better regulated. And these refrigerators do have a better circulation of air, which helps maintain a constant temperature. Also, segmented refrigerators are also available, which help us maintain better temperature. Dish preparation is generally given off to the junior most person in the lab, but unfortunately, this is one of the most important things that we do in the lab, because a slight delay in covering the media with oil would mean a change in osmolality. If you read the Jason Swain article, he emphasizes so much about the osmolality and how it actually affects the development of the embryo. It's actually eye-opening. So dish preparation should be done under LAF cabinet with air on to the minimum possible, and cover the culture media as soon as possible. The culture media droplet size, don't try to save money by making smaller drops. Smaller drops have a tendency to change osmolality fast. Bigger drops are slightly better. Optimize your culture system, optimize your dish preparation. I would encourage that 2 people make the dishes rather than a single person. Workstations, buy the better one wherein the temperature is actually stable. Most of the workstations have a slightly shoot up of the temperature and then it comes down, and then there is a fluctuation like a sine curve, and finally it stabilizes. So if your workstation is taking a lot of time to stabilize, please make sure you switch on your workstation much before your procedure actually starts. Handling biologicals, you must calibrate the surface temperature for every particular dish. Most laboratories turn off the airflow, especially when dishes are made, but this is not advisable. Otherwise, there is no point sitting in a lab chamber per se. Also note, if your dish is not, if the lid is not kept, and if there is no oil, the evaporation is faster. So when you're handling biologicals, make sure you're fast, efficient, and precise. And always keep a backup person standing by to pick up the dishes, keep it in the incubator, transport it, because every small movement will save time, and every single second or microsecond is important. Osmolality and humidity, I cannot but overemphasize the importance of this, because ultimately what matters is osmolality and pH, and the rest of the thing, that is CO2, the temperature, everything helps in controlling pH and the humidity of this. When it comes to micro manipulation, or let's say oocyte handling or micro manipulation, be it ICSI or be it embryo biopsy, speed matters. Do it in a heated stage. Do it using media which is not bicarbonate buffered. Use a HEPAS and MOPS buffered media, especially if the person is a beginner. If a person is a beginner, make sure you make the plates with lesser number of oocytes, because oocyte is the most vulnerable the biological in the entire system, because the entire chromosome network is in the form of a meiotic spindle, and one strand breaks means you end up in aneuploidy. Be very careful about the culture condition. Make sure your culture conditions are optimized. Nowadays, we believe in what we call as undisturbed culture. So look at a dish only when it is needed. You don't have to see a dish on day 2. If you actually do the first check, you can actually do it the next check on day 3 itself, or on day 5. Once you are assured of the quality of your works, of your culture condition, then possibly after FERT, you can actually just see on day 5. You repeated taking the dish out of the incubator to see whether the embryo is growing, not growing, of course, is not going to be very conducive to good growth. Also, select your media and disposable based on quality. Make sure you use the better media, better disposable. And there are a lot of new gaps and one must read between the lines when you choose all these things. Incubator selection is again of very paramount importance. It is the uterus outside the body. A lot of people try to mix and match media, but all said and done, most of these reputed companies, when they give a protocol, they have tried, tested, retested, retested million times before actually setting up the protocol. So please don't try to reinvent the wheel and try to mix and match the entire thing just because someone has said it or you think it is worth it. But your singular or possibly a limited experience cannot match the experience of the company which has done millions and millions of cases before actually putting the product into the market. Use accessory procedures when indicated. Don't use accessory procedures when not indicated. Use a deeper sperm selection, and especially when there is male factor. Use PSO-ICSI. It helps in certain cases. Oocyte activation definitely helps when there is previous fertilization failure. You can also use enhanced transfer media. Incidentally, one of these is only one which has an amber light as far as X-ray is concerned. PGT, when applicable, is also helpful. Slowly, we move on to the clinical aspect. I'm pretty sure I have not covered the entire embryology aspect. Swami sir will bear with me. So for that time, I'll actually shift on to the clinical aspects. The entire implantation would depend upon the quality and quantity of both oocytes and embryos. And what are the factors which actually has impact on this is the controlled ovarian stimulation, the type and amount of gonadotropins, number of oocytes retrieved, adjuncts, and the triggers that we use. So a lot of talk has been done between gonadotropin, antag cycles, and agonist cycles. But over the period of time, it has been shown that it doesn't actually matter whether you do agonist or antag cycles. There is not much benefit of one over the other. There is possibly some benefit of LH administration or recombinant LH administration when it comes to ladies of advanced reproductive age. The amount also apparently is shown to have no difference when it comes to cleavage rate or the capacity or the aneuploidy rate, because the incidence of aneuploidy in both aborted fetuses or in chorionic villus sampling, whether natural cycle was used or stimulated cycle was used, is found to be the same. In fact, one of the studies in around a decade back showed, this is one of the earlier studies, which showed actually the increased it negatively affected, the live birth rate was negatively affected when more gonadotropins were used per cycle. So when more gonadotropins needed to be used, it means the live birth rate might actually be lesser. So there are a lot of varying studies and varying results when it comes to these publications. What I would suggest when it comes to gonadotropins, use safer protocols. Increased dosages may give you increased oocytes and better results too in terms of numbers. But my personal humble view is make only those many embryos which are absolutely necessary. Just because a person is PCO, you don't have to beat the horse to give us more oocytes and unfortunately throw about 10 blastocysts, good-looking ones, because the lady has already conceived in the first cycle itself. So we are throwing life out. So please be a little ethical and make sure that you only make those many embryos which are required to actually give you a pregnancy. Of course, it's a very difficult call to take, and I would hedge on your maturity to take the correct call. A lot of things have been said. When you increase gonadotropins, does it increase the aneuploidy rate? It has been disproved, and all said and done, today the world believes that the only thing which increases aneuploidy rate is the maternal age and not the gonadotropin dosage which has been used. Even the ongoing pregnancy rate has an effect as far as age is concerned and not with the dosage of gonadotropins. Well, around a couple of decades ago, Bob Edwards had written an article wherein he actually said, isn't it time to actually minimize? Possibly he had a much farther vision as far as this entire protocols are concerned. He also advocated the thing wherein we use minimal stimulation, use IVM, and replace high-hitting routine IVF until and unless there has been a roadblock in the earlier procedure. Use adjuncts whenever necessary. I'll not elaborate on this. There are cheaper adjuncts, there are costly adjuncts. For example, melatonin is a pretty cheaper adjunct, and it has been time tested, but unfortunately, for some reason, has fallen out of agreement of a lot of people. Use adjunct when necessary. Also, use your trigger judiciously. we can also mix and match triggers. HCG can be used, agonist can be used, dual trigger, double trigger, FSH code trigger. And of course, the new kid in the block, of course, I mean, it's been around for some time now, more than a decade and a half, kisspeptin, which is common. And of course, kisspeptin can be used much in cases of PCOS, where we can actually avoid OHSS. Let's touch upon a bit on implantation failure. Implantation failure is, there's no classic definition, and the definition of implantation failure is still evolving. But to the best of my knowledge, if 3 euploid embryos have failed to implant in succession in a morphologically normal uterus with adequate endometrial proliferation, then it would be defined as implantation failure. One of the most important things which we actually ignore in our day-to-day practice is the important role that lifestyle has impact on the implantation failure. It is a no-brainer that increased BMI would mean less implantation. Smoking, definitely. I mean, I don't have to talk about smoking and alcohol. Easier said than done. We ask the patient to reduce stress, but all said and done, we can't just by saying to reduce stress, the patient cannot reduce stress. You have to suggest ways and means of it, either by walks, runs, yoga, breathing exercises. Please suggest all of this to them. Please don't suggest television as a way to reduce stress. Immunological factors, natural killer cells, if increased in number, definitely causes lesser implantation rates. An imbalance in TH1 and TH2 cytokines also cause an unfavorable environment. Interaction between maternal killer immunoglobulin-like receptors and the paternal HLA-C molecules also have an adverse effect on implantation. We all know the problems that antiphospholipid antibodies and anti-thyroid antibodies can cause when it comes to implantation, and later in pregnancy too. So when it comes to inherited thrombophilias like factor V, protein C, protein S, prothrombin, and MTHFR problems, we need to actually forewarn the patient and use certain drugs and chemicals, drugs to actually bypass this. Again, antiphospholipid antibody syndrome needs to be identified in cases of implantation failures and treated accordingly. Another very important thing which actually plays a role in implantation is the microbiome. It's also called as the other human genome. And it is said that microbiome might be involved in several steps of IVF, including gametogenesis, implantation, and delivery too. Make sure that the uterus does not have any abnormalities as far as anatomy is concerned, be it polyps, adhesions, fibroids, endometriosis. All these have an adverse effect. Please don't forget the male factor. It has been proven repeatedly that if the male factor has sperm damage, then the implantation rates are lower. Also, it also causes increased abortion rates. Abnormal packaging of this male DNA, that is, if there is a decreased P1, P2 ratio, that is protamine 1 and protamine 2 ratio, is associated with poor pregnancy rates and implantation rates too. Embryo factor, possibly the most important one. We actually grade the embryo by the help of morphology, but slowly but surely morphokinetics is coming into the picture as one of the most important factors. The other thing which actually also implants is aneuploidy. Affects implantation is also aneuploidy. And when it comes to a spontaneous abortion rate, around 70% is attributed to chromosomal anomalies when it comes to embryo factor. So please improve your lifestyle, cut BMI, no smoking, alcohol, limit stress, curtail and correct diet, most important things. Use the proper ovarian stimulation protocol, use the proper IVF or the embryo transfer protocol, use appropriate steps and avoid inappropriate steps just because it gives you a better margin. Use immunotherapy when it is used. It's still a little controversial. Guidelines not available, still evolving, but use according to your discretion. Anticoagulants do help in terms of when it comes to repeated implantation failure, especially due to the immunological causes. There are certain methodologies which improve endometrial receptivity, intrauterine infusions with HCG, PRP, GCSF, still evolving, no guidelines as yet. Scratch has been shifted out of the window. ERA, still controversial, only to be used in when it comes to research settings. relook at the probiotics that you're using. If there is implantation problems, visit the uterus again with a hysteroscope, revisit male factors, and sometimes do a PGT. There might be some structural issues with the chromosome per se. Now, till now we have been talking about the quality of the endometrium. What if there is not enough endometrium? It is too thin. Well, what is thin endometrium is still not very well defined, because even endometrium as thin as 4 millimeters have been shown to give pregnancy. But the optimal the range is somewhere around 8, 7 to 9 is what they say is the cutoff for frozen embryo transfers. As I said, up to 4 mm has also been reported to give pregnancy, but generally above 8 is what we generally look for when it comes to achieving pregnancy. So thin endometrium affects approximately 10% of our cycles. And this difference, there's a huge lot of difference between clinic to clinic, because there's a lot of variation in the methodology of measurement, the technique, the ultrasound equipment that we use, because there's a lot of non-standardization in the techniques that we actually use when it comes to measuring. So why does what are the causes of thin endometrium? Huge number of them: Asherman syndrome, previous history of DNC, endometritis, septic abortions, fibroids, etc., etc. So a lot of things where the uterus is not ready to actually receive the thing. So if at all, it's only thickness that we measure. Is there anything else that we can measure? We can actually measure volume with 3D. We can measure the pattern, the blood flow, uterine the endometrial contractions, and so on and so forth. So most important thing is to correctly do the TVS to measure the endometrial thickness. And there are other things like hysteroscopy which can also be done. Most of this still are on a evaluatory basis or a research setting. When it comes to treatment protocols, estrogen still remains the backbone of thin endometrium, but we can add on growth hormone, HCG, tamoxifen, vitamin E, aspirin, and also improve the blood flow with the help of sildenafil. All these things help. There are still more things which are appearing on the horizon. Botulinum toxin is one of them, stem cell therapy, GCSF, PRP, Chinese medicine, acupuncture, still at research stage. All said and done, this is a beautiful paper. This is, of course, the paper from 1995 where Applebaum had written, when he defined, or he suggested something called as the uterine biophysical profile. And this has been actually accentuated in one of the articles of a Chinese paper, which came in 22, which actually gave a scoring sort of a thing, wherein they measured thickness, volume, the echo, the lining, the peristalsis, and the blood flow, and it gave a scoring, and hence evaluated the endometrial receptivity based on these scores that he got. So one final word, I would say, don't just not give a person, don't give embryo transfer just because the endometrium is thick. If everything is normal, please do the transfer, because if the score is good, I think a transfer is mandated. Also, when you're doing a certain thing in a thin endometrium, please counsel the patient, tell them there's possibly a little risk involved in terms of success rate. And if nothing works, then of course, surrogacy is an option. Briefly touch upon ERA. It came in a big way about a decade and a half back. But today, the current guidelines of HRA say that there is still insufficient data to recommend ERA as a routine thing that needs to be done for RIF cases. Well, when we do an ERA test, it actually is a duplication of the cycle, of the transfer cycle, which we do on a previous cycle. And this is the results that we get. Receptive, early receptive, and late receptives are almost normal. If we get a pre-receptive or a post-receptive or a proliferative endometrium, that means the results are absolutely abnormal. So it helps us put the embryo at the correct time, and the ERA will actually tell us when the window of implantation is, where the window of implantation is. Just a second. So if you get a receptive endometrium, that means you are at the correct time. The biopsy time is the correct time when you actually when you need to put the embryo back. If it is early receptive, then you possibly have to delay the embryo transfer by around 12 hours. If it is late receptive, then you have to prepone the embryo transfer. If it is pre-receptive, you possibly have to do the biopsy after about 24 hours to see where it actually, whether you still get receptive, and accordingly you can, change your embryo transfer time. Similarly, when it comes to post-receptive, you have to do the second biopsy 1 day earlier. If you get a proliferative endometrium, possibly your progesterone has not gone into the body of the lady, or there's a problem with progesterone receptors per se. To finally conclude the talk, this last barrier of ART is still there. I mean, we still need to reach there. Just proves that we have a long way to go before we reach our destination and giving better and better results to our patients. There are so many possibilities at times. It is a paradox of choice, what to do, what not to do, what to choose. It is difficult, but I think the most important thing is to be transparent with your patient, talk to them as much as possible, take them into confidence and do the procedure, making them equally participants into decision making. It is almost like clutching the few straws when you're drowning. So what I would suggest is change your protocols, try adjuvants, possibly try some amount of experimental therapy. And as I said, counsel your patient, confide in them, clarify what you're doing, and that will give us better results, be it endometrial scratch, ERA, uterine flushing, immunological therapies which are still there, special medias that can be used, that is embryo glue and embryo things, can be used. It's the amber light when it comes to ASHRAE guidelines. PGT also would help in improving implantation rates. It's a long road ahead, and we still do have a long way and possibly a winding way to go before we reach the final destination. Thanks a lot. Thank you for the, firstly for the organizers, and secondly, the huge lot of audience that have sat down to listen to me. Thanks a lot. Over to you, Sindhuja.
Swami, you can please.
Thank you, sir.
Let Swami sir give some concluding thoughts before we go for the questions.
Yeah. Thank you very much, sir, for the insight. All we know that, we can't complete, implantation. Actually, we are fighting against the nature. So implantation is the ultimate sum of the efforts from all the people involved, from the clinician, from the patient, of course, the embryologist. Probably I will tell Sas the entire lecture in probably from 6 points, from starting from endometrial receptivity, and then the embryo selection and embryo transfer, luteal phase support, and immunological and molecular factors. Of course, last is the lifestyle and the adjunct therapies. So this is a very, very complicated thing. I think this is the secret behind, the implantation, the beginning of the life. We create embryos and it has to get implanted. It is a highly synchronized process. So I think we are inching towards understanding the implantation, how to overcome that. Probably once we understand this fully and the mechanism behind it, especially in the molecular level, I think we can give better results to our patients. Of course, we know the problems involved in creating the embryo. I always tell and advocate that, the embryologist job is not only creating an embryo, handling the embryo to become viable and selecting the best embryo, which you feel it is having all the qualities to implant from your side, because you know better than anyone else, because you are growing the embryo. There are 200 parameters to create an embryo. Sir mentioned few points, but a good embryologist will understand the impact of time, temperature, and other factors. I think we synchronize, we try our level best. Our ultimate wish is that we want to make every patient pregnant who visit our clinic, but I think it will take some more time, probably in another 50 years or so, because the technology comes and goes and the biology remains the same. Thank you very much, Scale team, for giving me this opportunity to chair this session. Over to Sindhu.
Thank you, sir. Thank you, Sandeep, sir. Thank you, Swami, sir. So we have a few questions in the chat box, but before we answer that, let's just quickly go through the questions. So now it's not going to be a poll because I want you all to actively participate. I'm going to just project the questions and Whoever wants can unmute and answer. It can be a group answer, doesn't matter. Just to wake you all up and so is my screen visible?
Yes.
Yeah. So the first question is, which part of the uterus is most commonly involved in implantation? Sir has said this word again and again and again. So it's a very basic question. Is it the endometrium, myometrium, perimetrium? Yeah, excellent.
Endometrium.
Great. Yeah. Okay, so let's go to the next one. What happens if implantation does not occur after fertilization? Does the fertilized egg die? Does the embryo grow in the fallopian tube? Is the egg absorbed by the body, or does menstruation occur as an end result?
Menstruation occurs.
Nice. Yes. So if fertilization doesn't happen, then menstruation occurs and the next menstrual cycle starts. So which hormone is primarily responsible for preparing the uterus for implantation? I think we all know.
Progesterone.
Yeah. The questions are very easy, no? Okay.
When you
So
take an
what is
exam,
the reason, sir?
when you take an exam, I'll be a student.
So what is the reason for implantation failure? I request all of you to read the answers. Yeah. So can be, yes. So it can be a structural problem. It can be hydrosalpinx, and not just poor embryo quality, even poor embryo handling in the lab can cause implantation failure. So only to highlight this fact, I've put this. So all of the above is the right answer. And everybody knows, all the clinicians will know. So ERA test helps to know.
Endometrium.
Yes. So if there are any embryology students, I also want you to be familiar with this term. So ERA test is for checking the receptivity of the endometrium. So if there is a test that is commonly used, kindly know what it is used for. That's all. So very, very basic questions just to make sure that students understand. So can we go to the questions in the chat box, sir, quickly? I think we are ahead of time, so I'm very happy.
2 questions on the chat box, I think.
Yeah.
The first question is, how can errors in the embryo grading by laboratory technicians lead to implantation failure or miscarriage in ART, ultimately causing suffering for patients? I think errors in the embryo grading by the laboratory technician, how it can impact ART outcomes and miscarriages, and ultimately, patients having a
Yeah, it's very simple. I mean, if you can't grade an embryo properly, it is something like, giving the first rank to an undeserving student. So you might actually increase what we call as time to pregnancy if you can't grade the embryo properly. So we generally, as clinicians, would want to put the best embryo first, and then the subsequently. I mean, so first part is, if you can't grade the embryo properly, and you say it's a grade 1 embryo, it raises the hopes of the patient, and then ultimately it might not really work. So that is one way it increases the suffering of the patient.
Okay. The next question is, which is the best antibiotic that can be given for chronic subclinical endometritis?
Oh, Vasundara, would you want to take this?
Yeah, I think most of the cases should respond to doxycycline twice daily, but then chronic endometritis, I believe, should be a proven diagnosis. I think it should be a hysteroscopic diagnosis, and you should send the endometrial sampling for CD138 and identify plasma cells. However, definitely we're going to do that exercise in a couple who has had 2 or 3 failures. So even after one embryo transfer good quality failure, all of us are going to definitely assess for chronic endometritis. I think if doxycycline doesn't work and you don't have a culture sensitivity report, the other thing which is really effective is cynomycin, which you can use 200 milligrams HS for 14 days. And little out of the label, but people have used and it's got real good effect, is your Placentrix injection, which is really worked in chronic endometritis. You can give along with your antibiotics, and most important in these cases, please add a probiotic. That is very, very important to normalize the uterine milling. So that's very important.
I absolutely agree with Vasundara, and most important thing is, it's not just important to give antibiotics, but once the antibiotics over, you should cover it with a probiotic so that the correct bacteria actually grows in.
So one other question is, after ovum pickup by needle, is there a risk of complication with the corpus hemorrhagicum, corpus luteum, which are essential for maintaining pregnancy?
Well, I mean, it really won't matter too much because anyway, when you do the ovum pickup, most of the granulosa cells are sucked out. So the corpus luteum, which is formed in a ovum pickup case, it wouldn't be very suitable to actually give, secrete progesterone. That is the reason why we have to actually substitute or we have to augment progesterone supplementation, especially if it's a fresh transfer. I assume that the question is asked in reference to a fresh transfer. So even if there is, until and unless the bleeding causes a problem, it will, since most of us would also give supportive progesterones after an ovum pickup, I don't think per se a couple of hemorrhagic cysts or a hemorrhagic corpus luteum will really matter when it comes to supporting pregnancy.
Can we take one or two more questions? One-step media or sequential media, which is better in your opinion?
Is it for the embryologist or the clinician?
Yes, probably.
Okay, I'll take it. I mean, all medias are good. Okay, when you talk about the world started from what we call a single-step media, slowly moved on to sequential media, and now because of ease of use and possibly a lot of time-lapse imaging coming in, people have moved back to single-step media. But all said and done, all medias are good. What is most important is to use them properly and use them as far according to the directions that are being given by the manufacturer.
Are there any additives in the culture media that can improve, implantation, especially in previous failures?
There's only one additive which they actually say, that is, sorry, I'm not getting the name, hyaluronic acid. That improves this thing, but there are a lot of other things like GCSF, HLA and all, which are all added. But unfortunately, these culture medias, they don't actually give the exact concentration on what is added into the additives. But the hyaluronic acid is given an amber light when it comes to X-ray guidelines.
Can you share some very important tips about embryo transfer that can affect your implantation from the time the embryo is coming from the lab to the uterus? So few practical tips that should be followed to avoid problems with implantation.
Okay, I think the most important thing is the operator. I mean, there are two operators here. One is the embryologist and the second one is the clinician. Both the embryologist and the clinician should know what the other person wants. That is number one. So the entire procedure should be a very smooth thing. You should be communicating with each other. I think the time from when you actually start the stopwatch and get your dish out and onto your workstation to the time that the embryo is implanted into the uterus should be less than 1 minute. That is the most important factor when it comes to implantation rate vis-a-vis the embryo transfer procedure. Most of the times what happens is the embryologist is new, the person holding the probe is changing, we all are in a high stress environment. Firstly, important thing is to reduce the stress levels in the embryo transfer OT. Possibly play some soothing music. Tell your embryologist exactly how you want your embryos. Some clinicians want just put the outer and the embryologist puts the inner and pushes the thing. So whatever you want as a clinician or you want as an embryologist or what the clinician want must be clearly conveyed amongst you two before you actually start the procedure. Make sure that the bladder is adequately full. Make sure you see the lining properly. You tell your sister where exactly you want to place the embryo or the person who's holding the probe, where exactly you want to place the embryo and from where to where she has to show you on the ultrasound. I think any hitches in all these smooth flow is the main impediment to implantation when it comes to embryo transfer procedure per se.
Thank you for those insights. Also, there's one last question. Sometimes we see an endometrium of 8.5 and, everything is good for transfer. And then, there is something called as endometrial compaction. After the start of progesterone, the endometrium tries to compact. Is the compacting endometrium is good for implantation, or if the endometrium doesn't compact and if it's like that, it's better? Which is going to give us a better implantation?
Well, the ultrasound is never a correct picture of what actually happens within the thing. But if your dosages are right and you are not hyper-estrogenizing the endometrium or hyper-progesteronizing the endometrium, I think everything will be working well. Ultrasound per se will not be the
Ovulation is a physiological feature that should happen post your progesterone, right?
Yeah.
Okay. Any other questions, Sindhu, which you can see? Or
I think everything has been answered, ma'am.
we request all the members to kindly share your feedback about this program. And
The feedback link is in the chat box, please. No?
so if there are no more questions, I think implantation has been covered extensively by Dr. Sandeep. Thank you so much wholeheartedly, whether it's the seed or the soil, whether it's the lab factor, whether it's the clinical factor, whether it's the lifestyle factor, it's still a black box. I think all of us have to work on how to improve these implantation rates and keep upgrading ourselves on what is the best clinical practice for our patients. Thank you so much, Dr. Swaminathan, sir, for honoring us and agreeing to chair the session for SCALE program. Thank you, all the audience. Thank you to Dr. Sindhuja for her wonderful academic coordination and efforts taken to make this, a seamless event. I can't thank everyone here enough. Let's again meet on March 6th with our next masterclass series, which is going to be about all about oocytes, and it's going to be a lecture by Dr. Rajvi Mehta. To see you all on 6th of March. Thank you so much. Thank you. Thank you so much.
Thank you, Vasundara. Thank you, Sindhuja.
Thank you, sir. Thank you, sir. Thank you, ma'am.